So let's go ahead and actually get started. All right, let's get seated. So, yeah, perfect. All right, thank you so much. So I'll get started actually. So this session, we're going to talk about the advances in the management of localized lung cancer. So we're going to focus in this particular session just on non-small cell lung cancer. Small cell lung cancer will be discussed later on this afternoon when we go over some cases, okay, in the case management portion. So here are my disclosures, because this is actually a CME course. So this is the outline of my talk. We're going to go over actually two aspects. So localized lung cancer, not only just the patients who are getting treated with radiotherapy, who are considered inoperable, unresectable, but also we're going to spend a considerable amount of time also on the operable patients. And these are the patients with stage 1 to 3 non-small cell lung cancer, or we would consider localized lung cancer. So we'll talk about some adjuvant and neoadjuvant therapies for patients with operable lung cancers, and also patients with inoperable stage 1 to 3 lung cancer. We'll talk about in early stage lung cancer as well as locally advanced lung cancer. So this is going to be a didactic. It's mostly education, but if you have any questions about management, please pose those at the end, okay? So actually, I start off with a question. I believe this is going to be linked, and if you have your phone, you can actually do this as interactive way. So this is a question for you, and I want to see how you, for this particular case, how you manage this particular patient. So this is a patient with a potentially resectable stage 2 non-small cell lung cancer. What would be the best management strategy for these patients? A, biopsy to determine genomic status of patients before starting therapy. B, induction chemotherapy followed by surgery. C, induction chemo and immunotherapy followed by surgery. D, surgery followed by chemotherapy. Or E, surgery followed by chemotherapy and immunotherapy. Okay, so if you have your phone, I'm not sure if you're seeing question on your app, okay? And then we can actually have the audience survey and see how you guys answer. All right, so we'll go ahead and take a look at the responses. All right, so actually a pretty good distribution, particularly for A and D. So biopsy determined genomic status, or D, surgery followed by chemotherapy. And then some answers, some induction therapy, and then in C and then E, surgery followed by chemoimmunotherapy. I think you will see from the discussion that it is actually there's not exactly a right answer here. Really depends on the scenario, okay? So we'll talk about that as we go forward, all right? So there's really no right or wrong answer in this case, all right? So these are the treatment options for operable stage 1 to 3 non-small cell lung cancer. Certainly in the stage 1, really early stage, patients will receive surgery alone. And then a little bit more advanced, stage 1B to 2, surgery followed by adjuvant therapy. These are mostly patients that you think they have early stage disease. The operated on may have a little bit more advanced disease. And then patients who are known to have more advanced disease up front, these days, it's actually patients are often approached with neoadjuvant therapy. And we'll go over some of the evidence actually related to that. You know, surgery is still considered the first line for operable stage 1 to 3. Wedge resection, of course, has been recently demonstrated that could be adequate for patients with very early stage peripheral tumors. However, lobectomies and in some patients even pneumonectomies could be potentially an option for these patients. And then segmentectomy is a reasonable compromise. However, it has been recently shown as well that segmentectomy can actually have equally as good an outcome for patients with small tumors. There's some, of course, incidence of postoperative mortality, but however, with treatment advances, this is actually, of course, the rates are low. However, there's still, of course, a rate of distant spread disease, even in patients with early stage disease. For all stages of disease, distant metastatic disease is still the predominant pattern of spread for patients. You know, 20% of these patients will recur local-regionally, 10% will actually recur both locally and distantly. However, within 2 years after surgery, 60% of the recurrences will occur. So now the question is actually, can local, regional, and distant control rate improve with adjuvant therapies, whether it's actually chemotherapy or some kind of systemic therapy or radiotherapy? And I would like to go over some of these, some of the trials and, of course, some of the controversies related to this. So actually, of course, for decades, this is actually in the early 80s, as well as actually in office in the 90s, adjuvant chemotherapy was finally shown to actually have improvement after surgery. And this is a latest meta-analysis actually involving several thousand patients, showing a 5.4% overall survival benefit with the use of adjuvant chemotherapy after surgical resection. Does not benefit patients with small disease like stage 1A. However, patient with a little bit more advanced disease, stage 1B and above, there's potentially a benefit with the incorporation of adjuvant chemotherapy. However, at 5%, that rate is there's still a lot of room for improvement, and that's the reason why in the 2000s, okay, so before the 2000s, it was just chemotherapy has been the standard. Since of course, the advent and the discovery of immunotherapy and the benefits shown, there's been, of course, trials incorporating what would there additionally benefit after adjuvant chemotherapy. So the incorporation of immunotherapy came about in the 2000s and beyond, 2010 and beyond. So the Empower 10 was a phase 3 randomized trial of adding atezolizumab or best supportive care after adjuvant chemotherapy in patients with resected operable stage 1 to 3 non-small cell lung cancer. So all these patients actually had 1 to 4 cycles of standard chemotherapy based on the discretion of the medical oncologist. And then there were one-to-one randomization to atezolizumab or best supportive care. The primary endpoint is actually disease-free survival, and as you can see here, based on the Empower 10 trial that was published a couple years ago, in patients with, particularly with some PD-L1 expression, there is a significantly improved DFS, disease-free survival, in patients who receive atezolizumab compared to best supportive care. However, there is actually potential benefit of neoadjuvant therapy, and the neoadjuvant therapy is defined as actually having some therapy before surgery. So in patients who you deemed maybe have a little more advanced disease, these patients will undergo some neoadjuvant therapy, and then based on the response, potentially go on to surgery. Of course, they have no evidence of progression. Some of the benefit of a neoadjuvant therapy is that it potentially can treat micrometastatic disease earlier. So the reason why these patients fail, they are high risk in patients, particularly with stage 3 disease, is that they may already harbor micrometastatic disease. So therefore, starting neoadjuvant therapy potentially can treat these micrometastatic disease. It also increases compliance because a lot of times after surgery, these patients already kind of have some complications and some toxicity from the surgery. Oftentimes, they cannot tolerate adjuvant therapy. So starting neoadjuvant therapy before any other therapy starts can potentially increase compliance. And also, you can actually assess treatment efficacy, particularly based on the pathologic complete responses that you see. And this is a way, potentially, not only develop therapies, but also understand the biology of your cancer and incorporating novel therapies as well. And this is a way potentially can make advances much faster. In the adjuvant setting, you have no disease to track, so therefore there's no way to know whether your drug is actually working or not. So that's the benefit of neoadjuvant therapy. So the Checkmate X16 was, of course, the trial that demonstrated that. It was actually, a primary endpoint was event-free survival. And this actually now is really a new standard of care. And of course, this is a trial that randomized patients to induction chemotherapy, which is actually one standard as well in patients who are resectable. Some of these patients get induction chemotherapy prior to surgery. And then, of course, this trial actually added immunotherapy, in this case, nivolumab, with chemotherapy, and actually showing a significant improvement in the event-free survival with the incorporation of nivolumab with chemotherapy. What's important is actually the pathologic complete response is a very important predictor, or actually even a major pathologic response is a major predictor for outcome for these patients. So you actually see here, you see on the curves, if I can point to you here, so you can see on the curves is that, even in patients who get chemotherapy PCR, so there is only about 2 to 4% patients who just get induction chemotherapy will have complete pathologic response. These patients are cured, actually, have much higher cure rates, but however, if you look at here, is that very small number of patients actually have complete pathologic response with just chemotherapy. However, with the incorporation of nivolumab, you have a much higher frequency of complete pathologic response, and these patients do very well, of course. These patients potentially can eliminate micrometastatic disease, and these patients have much better long-term outcome. So to build on this, there's actually been a number of trials, and I don't have time to go over all the studies that's out there. One of the studies, of course, is the AstraZeneca study, and that's led by Tina Cascone at MD Anderson, where it's called NeoCOAST, where they actually incorporate multiple agents with durvalumab. So durvalumab is actually one of the control arms, quote unquote, and they incorporate other agents in combination. These are combination immunotherapy. Now there's trials in combination with chemotherapy and other immunotherapy combinations to see, and then of course these patients undergo surgical resection. And the primary endpoint is actually looking at major pathological response as a surrogate of the benefit and the efficacy and the effectiveness of your combination therapy. So there's many trials. I'm not going to go over it. This is one trial that's actually ongoing. There are others designs as well by many other companies doing the same thing. However, this is actually, of course, these patients, that receive the immunotherapy patients, immunotherapy drugs, are not the patients that have EGFR mutations, right? These are all patients who are EGFR wild type or ALK wild type. They don't have oncogene drivers. It's well known, of course, patients with oncogene drivers do not respond to immunotherapy. And it's been actually, lots of data has been demonstrated that this is a meta-analysis that showed in patients, if you look at patients with EGFR wild type lung cancers, this is a patient with stage 4 disease. And if you look at a patient with EGFR mutated lung cancers, and you look at, and these patients are enrolled on all the various immunotherapy trials, patients with EGFR mutations do not respond to immunotherapy. And there's actually, it's known there's some putative mechanisms. It's actually, these EGFR mutant lung cancers tend to actually create an immunosuppressive state within the tumor microenvironment. And therefore, that's why these patients do not actually respond to immunotherapy. So the best therapy for these patients are actually going to, of course, be EGFR TKIs. Here in Asia, of course, particularly in Taiwan, there's a lot of patients with EGFR mutations. So this is obviously a very relevant issue. So, and that's the reason why the importance of ADAURA trial, which you guys are totally well familiar with. These are patients, of course, that receive adjuvant osimertinib, which is third-generation TKI, in patients who are EGFR mutated and resected stage 1 to 3 non-small cell lung cancer. So you know from the results, it's a 1-to-1 randomization after a surgery, and of course, knowing their genomic profile for EGFR, targetable EGFR mutations, they're randomized to osimertinib or placebo. And as you can see, this is probably the most important and incredible results that we've ever seen for any kind of drugs, right? Any trials, is that they can say, they often say that you can drive a Mack truck through the Kaplan-Meier curves, because that separation is absolutely unheard of, right? So you can see here that because the hazard ratio is like 0.23, not only for disease-free survival for these patients, but more importantly is actually now there's a press release, right? Although we don't see the results, but the press release that overall survival is also benefit from patients receive osimertinib. So that's very exciting. Probably will come up in the upcoming, one of the upcoming meetings, particularly probably ASCO. And of course, actually, if you stratify based on the stage, patient with stage 1B, there's still a benefit, although the relative benefit is smaller because these patients have much lower risk of having metastatic disease. But of course, the benefit is much greater for later stage disease, particularly patient with stage 3A disease. So that's now, of course, osimertinib is now standard of care in the adjuvant setting. Now there's actually now increasing role, potentially even asking the question whether we should do neoadjuvant osimertinib. So there is a trial called NEO-ADAURA, which is ongoing, which adds whether there's a benefit. There's actually some biology issues in the sense that what they found is that actually there's some results, early results that don't show this results here because it's not yet published. What they found is that with neoadjuvant osimertinib, there's not an increased pathologic complete response, actually. What you see, there's actually increased senescence. You induce senescence with osimertinib. So there's some question whether that's going to improve outcome in the neoadjuvant setting. And actually, even for this as well, is that in the adjuvant setting, in terms of do we truly improving outcome? Although survival, you see there's some improvement. But however, when you withdraw osimertinib in the long term, is the disease going to actually just return, right? So there's that ongoing question for this trial as we follow patients longer. So there is actually, so a patient with stage 3 disease not only have risk of distant metastatic disease, but also they have risk of local regional recurrence, right? And that's the reason why there's consideration for radiation has been used in the adjuvant setting. And so, but however, this question has been answered for many decades, right? In the 60s, we know that after surgical resection, patients recur not only distantly, but also local regionally. So therefore, the use of postoperative radiotherapy was actually used and tested in many randomized trials, in very, very early randomized trials. And all these trials basically uniformly demonstrated that postoperative radiation can improve local regional control. But the problem with these trials is that none of these trials really demonstrated overall survival benefit. And actually this, in the Port meta-analysis really showed this, is that if you actually look across all the randomized trials, you can see here is that there's actually a detriment in patients with early stage disease to receive post-op radiation. And there's essentially equivalence. So there's not either a benefit or a detriment in patients who receive post-op radiation in patients with more advanced disease, particularly in stage 3 disease. And so there's some caveats saying, well, these are old techniques, right? There are some of these patients will receive Cobalt 60. There's some poor techniques used. And of course, there's very high rates of mortality due to the treatment itself. So a lot of these patients develop and die from cardiovascular as well as cardiopulmonary toxicities. And therefore, so their question is actually whether, in the modern era, using modern radiation, would that improve outcomes? So therefore, they had to repeat the modern trials, and the reason why the lung art trial is so important. This is a more modern trial that was actually just recently completed. Took many years, started in 2007 and ended just 2018. It was done in Europe through the ERTC. Really, most of these patients, a few of these patients got IMRT, majority of patients got 3D conformal, however, still using modern radiation techniques. So patients were randomized to post-op radiation. Some of these patients got chemo, depending on discretion of the medical oncologist. However, they were randomized to post-op radiation versus not. And unfortunately, and you guys know the results, it was published a couple years ago that the lung art trial did not show there's an improvement in disease-free survival. However, if you actually look at what I highlighted in the box there, is that in the postoperative group, there's still a high rate of deaths from cardiopulmonary disease, right? So 8% of the patients are dying from cardiopulmonary diseases, which is not what we expect, actually, in our experience, of course, even in the United States, is that most of the post-operative, in terms of adjuvant setting and death from complications is very, very low, typically less than 2%. So this is pretty high, and when we looked at this, we criticized it, saying, well, they're using bad techniques. Why not using IMRT? Maybe protons might be beneficial, right? Might be better. So we started criticizing it until the Chinese results came out, right? So it was published in JAMA Oncology. It's also a similar randomized trial, phase 3 randomized trial done in China. Very similar design. These patients actually received post-op radiation, randomized to post-op radiation versus not. 90% of these patients receive IMRT, however, right? So we cannot criticize based on bad techniques. And the primary endpoint is 3-year disease-free survival. And unfortunately, it was a negative trial. There was no improvement in disease-free survival in terms of overall, because actually, of course, disease-free survival is a composite of not only recurrence, but also overall survival. And you can see here by the overall survival curves, there was no difference between the post-op radiation arm versus the observation arm. However, the paper did show that local regional control was improved with post-op radiation. It's just not the overall survival. So almost kind of taking us back to the past is that we always see that local regional control is improved with post-op radiation, just not the overall survival. Probably because in this modern era, we actually have much better systemic therapies, and therefore probably that's why we're not seeing overall survival, because the salvage therapies are so much better nowadays. So radiation, while we can actually improve local regional control, we're still not able to improve overall survival with just the use of adjuvant therapy, radiation therapy. So with that, this is a summary of part 1, and I'm going to look at my time. So surgery is still considered first line in localized non-small cell lung cancer, and that adjuvant chemo-IO is now the standard for non-EGFR ALK mutated lung cancers. However, osimertinib is now the standard in resected EGFR mutated non-small cell lung cancer. However, neoadjuvant therapy is now actually probably a new paradigm by which new drugs will be developed, because it have a much greater potential for developing novel therapeutic approaches. Post-op radiation is still used, however, very limited now. We only use it for patients with multi-station disease, particularly, of course, for patients with positive margins. We incorporate it with their systemic therapies. All right. So now I'm going to inoperable, of course, my favorite topic as radiation oncologist. So we're going to talk about early stage disease as well as locally advanced disease. All right. So I'm going to go over this question, and then go ahead and have your cell phone take a look and see your responses. So in a patient who presents with inoperable stage 3 non-small cell lung cancer, what is the recommended strategy for management? A, induction chemotherapy followed by chemoradiation. B, induction chemotherapy plus immunotherapy followed by chemoradiation. Chemoradiation followed by chemotherapy for 4 cycles. D, chemoradiation followed by immunotherapy for 1 year. Or E, chemoradiation with concurrent immunotherapy followed by immunotherapy for 1 year. Very good. All right. So a majority of the audience answered D, and there's probably a right answer here. Is D. Some patients, some of you chose some induction chemotherapy and immunotherapy followed by chemoradiation. I think it's increasingly used, I will say. right? Because especially nowadays where a lot of our medical oncologists would like to consider whether surgery can be done after chemoimmunotherapy. So that's not a wrong answer, B. And then E, we actually we'll see what PAC2 shows. Specific to was a trial doing that exact same thing. And of course, ECOG Akron 5181 is a trial, randomized trial that's ongoing, asking this question whether concurrent immunotherapy will benefit. So we'll go over actually just the management. Stage 1, early stage lung cancers. SABR is really the preferred option. Of course, not conventional radiation if possible, and of course, more locally advanced disease, particularly M-positive disease. Chemoradiation followed by consolidation durvalumab would be considered the standard of care. And of course, when we talk about SABR, is stereotactic ablative radiotherapy. These are truly ablative doses of radiation that we do. This is defined as less than or equal to 5 fractions of radiation, trying to achieve a BED, a biological equivalent dose of greater than 100 gray at least. 130 gray is what we try to achieve ideally to the IGTV. And of course, this will all be done either under cone-beam CT or image guidance. But now, of course, with the MR, particularly MR-guided radiotherapy, that's actually, if you have that technology, access to that technology is certainly beneficial, particularly for more centralized disease. Of course, the prescription that we use for more peripheral is actually for small tumors. Sometimes you can actually just even 1 fraction of 34 gray. A little bit larger tumors probably start more fractionated, even 3 fraction, 4 fraction, 5 fractions. Larger tumors or more centrally located tumors, it ranges from 8 fraction to even 15 fractions for larger tumors in centralized disease. And I kind of show it here in the next slide there. And so this is a trial, of course, that show that if you have an option, do SABR, do not do conventional fractional radiotherapy. This is, of course, a study that was done in Australia that compares head-to-head, comparing SABR versus conventionally fractional radiotherapy over 30 fractions or even 20 fractions. You see here is that, of course, SABR completely improves survival. Not only local failure free survival, but also overall survival compared to conventionally fractionated radiotherapy. Onishi actually, of course, have demonstrated this in his large retrospective reviews, that patients receive SABR should actually receive a SPRT dose greater than 100 gray BED to the GTV. In patients who receive less than 100 gray, there's actually a detriment in their not only low control, but also overall survival. So if you incorporate ablative radiotherapy, why don't we actually just use it for more operable patients, right? Because since we have such great local control, and actually, but surgeons will say that their survival is poor, right? If you compare head-to-head between surgical patients and patients with SABR, the survival is worse. Well, the patients that we see that receive SABR are patients with unresectable disease, so they already have cardiovascular, COPD, they're going to die not from cancer, they're going to die from these other diseases. So now can we actually move SABR to operable patients? Are we going to get the same outcome? Well, we know from the Japanese series that in the patients who refuse surgery, and if you look at their series of operable patients, their outcomes are really good, right? If you look at the 3-year overall survival, 80%, and in these patients, in these 2 series that was published from Japan. And you actually compare to the surgical series. This is actually CalGB 9633, which is a trial that actually asked the question, the randomized patient to adjuvant chemotherapy after surgery versus observation, but just using that data to look at their survival outcome. Even the control, even the patient that got adjuvant chemotherapy, you look at the 3 overall survival is 80%, right? So it's suggesting that actually patients who receive adjuvant just SABR without any therapy afterwards, the outcomes actually can be quite good, potentially even comparable to patients who receive surgery plus or minus chemotherapy. So can we do this head-to-head? Well, there have been many randomized trials internationally trying to do this. Can we compare head-to-head surgery, lobectomies with SABR? But unfortunately, all have been terminated early due to failure to recruit because surgeons would not refer those patients, right? Because that cuts into obviously, their bottom line. So, Dr. Chang, of course, Joe Chang is one of the radiation oncologists that attempted to do this. Even in MD Anderson, it was difficult to do. So he conducted a port analysis with his Spanish trial called Roselle and our MD Anderson trial called STARS. It was a very small number of patients. So only 58 patients combined with the 2 series. So 31 patients got SABR, 27 patients got lobectomy. And of course, you probably noticed with these results, the outcomes, you will say it's comparable. all those survival curves looks better, actually statistically significantly better with SABR compared to surgery. But of course, these are patients who, unfortunately, for luck or maybe bad luck, that patients that were randomized to surgery, some of these patients died. One patient that died, so therefore any small number of changes, of course, you see a compromise in the survival curves. Of course, no patient died from SABR, and that's the reason why you have such good survival curves. Of course, no difference in recurrence-free survival between the two. And of course, no differences in local, regional, and distant failure between the two. So, of course, this received a lot of criticisms. It's a small study. It's actually combined analysis, so therefore it's definitely not a randomized trial. And even actually the MD Anderson surgeons that actually were authors on this trial, they went to surgical meetings, they were criticized severely, right? And so, of course, if you actually look at the adverse events, and that's a cause for why maybe SABR is better in this case, because you just don't have the complication of surgery with SABR. So you can see here in the patients in this particular study, one patient died from surgical complications, but there's also surgical complications that potentially can result for death as well. But then for SABR, there's minimal toxicities. You know, a lot of the patients that we see with lung cancer are elderly patients, and there's been actually a population-based data where you can see here is in patients who actually receive surgery and they're elderly tend to actually develop most of the complications as well as death from surgery. So this is, if you actually, sorry, you know, this is a pretty complicated slide. But here is that, so if you look at the upper panel here, these are younger patients, but then if you see here, patients 70 years or above, then you can see the separation between the mortality rate, 90-day mortality between patients who receive surgery versus SABR. So separation happens in the elderly patients. So therefore, in patients who are even potentially resectable, but if they're elderly above 65, these patients can potentially have higher risk of dying from their surgery, and SBRT may be better for those patients. Well, Dr. Chang, Joe Chang, and MD Anderson actually conducted a single-arm study called the revised STARS. It was actually a continuation of their previous STARS randomized trial, but be converted to a single-arm study looking at potentially operable patients, and they were sent by our surgeons to enroll onto the study. So there were 83 patients enrolled to the study, and you can see here, and this was reported a couple years ago, showing that the outcomes are tremendous, right? This is SABR patients, overall survival, disease-free survival. And there's a plan analysis about actually doing a match analysis to patients who receive VATS lobectomy. So this is a pre-plan. So they identify those patients up front, and the patients that were on the SABR trial, they identify from the surgical database match patients that have all related to age, gender, et cetera, based on stage of disease as well. And you see here it's complete overlapping. So that means suggesting that potentially SABR patients, the outcomes are practically comparable to even VATS lobectomy where have low surgical complications. But it's not a randomized trial, right? So we still need to do the randomized trial. This is the only randomized trial that I know of that's actually being still enrolling patients. It started in April 2017, and this is done in a VA hospital where there's less bias because the pulmonologists are the one who actually they do the diagnosis and they randomize and only send to the surgeon or send to the radiation oncologist. So there's less bias from the time of consultation. So this is a trial. Hopefully, we'll see the results and demonstrate that at least we're equivalent to surgery resections. So the patterns of failure, of course, these patients, despite having, whether they're operable or inoperable, these patients still have rates of distant metastatic disease. About a quarter of the patient will develop the metastatic disease. And you can see here is that it's very similar to patients who receive surgeries, that there's about the same, similar, about a quarter of the patient would develop metastatic disease even after surgical resection. So there's no difference, right? These patients they still have this high rate, this incidence of metastatic disease. And therefore, there's a need for adding adjuvant therapy after SBRT, SABR. So MD Anderson, a phase 2 randomized trial was completed called iSABR, also conducted by Dr. Chang. Completed about a year and a half ago. He's actually reporting at ASCO. And then, of course, there's 2 randomized trials called Pacific 4 as well as SWOG 1914 that's currently ongoing. These are phase 3 randomized trial, either using durvalumab or using atezolizumab. So we hopefully that this will actually further improve the outcomes for these patients who receive SBRT. Now we're going to go on to locally advanced disease. These are locally advanced unresectable non-small cell lung cancer. Actually, the dose of RT was established in 1980 based on RTOG 7301, right? And actually, since that time, we have not, at least the dose of radiation has not really changed. And we know, of course, from 0617 that 74 gray is not beneficial, right, compared to 60 gray. So at least the dose of radiation is fixed. The only thing that we advanced since 1980 was the use of chemotherapy with concurrent. That's concurrently used with radiation, right, based on RTOG 9410, right? But now, based on the Pacific trial, we're adding consolidated durvalumab is now the standard of care after concurrent chemoradiation. But if you actually see the benefit of concurrent chemoradiation, it's actually very small. Then this is based on meta-analysis. Compared to just radiation alone, the only benefit is about 5% also, 3 to 5%. 3% for patients who receive sequential chemotherapy and radiation, and about 5% for patients who receive concurrent chemoradiation, with a substantial increase in toxicity with concurrent use of radiation, chemotherapy and radiation. However, it is a standard of care that we're building on. And of course, RTOG 0617, 74 gray is not beneficial compared to 60 gray. There's actually even, if you look at the curves, the lower curve is actually 74 gray, suggesting that it's a detriment for using higher dose. So 60 gray is really the standard arm. And therefore, the Pacific is probably the most important advance that we made in unresectable stage 3 non-small cell lung cancer. You know, of course, this is a 2-to-1 randomization between durvalumab and placebo. And of course, this is a 5-year update of overall survival with the intent to treat population. There's about a 12%, 13% improvement overall survival with the use of durvalumab, and is durable even after 5 years. And it's currently the standard of care. Now, of course, this is being built. Now, AstraZeneca is building on this with the COAST trial, this COAST phase 2 randomized trial. Now the control arm is the durvalumab arm. Now they add 2 other additional agents called oleclumab or monalizumab, along with durvalumab. And the mechanism of the disease, actually, the oleclumab is the anti-CD73 antibody that actually that binds and inhibits the adenosine pathway, which is one of the immunosuppressive mechanisms used in tumors. And then, of course, monalizumab is a NKG2A antibody that activates the NK natural killer cell mechanisms. So this was reported actually in ASCO and in the JCO last year that they found, despite the fact that the durvalumab arm, the outcomes are actually quite poor, but they did find a statistically significant benefit with the use of the combination of either oleclumab or monalizumab. And because of these results, this is the Pacific 9 design. This is a phase 3 international randomized trial, placebo-controlled, testing whether monalizumab or oleclumab is going to improve outcome compared to durvalumab alone. But there's many other trials out there. There's just no time, actually, to even talk about this during this small session and short session. There are many trials actually testing, you know, not even different drug combinations, but even sequences of these combinations. But then actually but this would not apply for patients with EGFR mutations, of course. So that's why the LAURA trial is so important. These are patients with unresectable EGFR mutated lung cancer who will receive osimertinib in consolidation versus, but not durvalumab, because we know in patients who receive durvalumab EGFR mutated do not respond. So this is a LAURA trial. It actually has completed. Hopefully, I think it will read out very soon. I think this year it will read out, at least based on the feedback from AstraZeneca. We believe it's going to be positive, right? If it's negative, it would be completely surprising, right? So they're already talking about the next trial, actually, after LAURA. So they may even consider adding chemotherapy to osimertinib potentially as the next trial. So I'm actually happy that I'm actually finished on time here. So here's the summary of part 2 in unresectable non-small cell lung cancer. SABR is the standard of care for early-stage non-small cell lung cancer and should be used for all patients with unresectable early-stage non-small cell lung cancer. In the operable patients, SABR is an excellent option for those who refuse surgery. But however, in future randomized trial, is really needed to compare SABR plus IO versus surgery plus IO. Now the question is actually, which is the best local modality to combine with immunotherapy? Unbiased, I believe SABR is going to be a better combination. Because of, I don't go over the mechanism, you guys know about that, right? There's a potential for the abscopal response, the tumor presentation with SABR. Surgery, you don't get that. Surgery removes all the antigens from the patient. So therefore, you don't have that synergistic benefit. You have the systemic benefit separately from the local benefit. However, with radiation, you have the combination benefit. So I believe, hopefully in the future, I don't think it will ever be done. However, SABR IO versus surgery IO should be compared. I think for locally advanced M-positive unresectable non-small cell lung cancer, of course, chemoradiation plus durvalumab is the current standard of care. However, further improvements will soon be realized with additional immunotherapy combinations. But of course, for EGFR mutated non-small cell lung cancer, consolidated osimertinib and LAURA should be the standard after chemoradiation. But now future trials are currently being planned in a cooperative group setting for other oncogene drivers such as ALK, ROS, KRAS, G12C, MET, exon 19, exon 14, et cetera, et cetera. This is all being designed currently with multiple arms and in collaboration with multiple companies supporting various TKIs in this setting. With that, thank you. Be happy to take any questions, management questions, et cetera. So what do you guys do? Do you guys do chemo IO in neoadjuvant setting quite often now, in terms of even patients who are borderline resectable? I don't know. Do you see a lot of these patients? And how are your medical oncologists managing these patients currently? Because that's one of the problems that we see is that a lot of the patients that initially in the past with multi-station disease oftentimes would just refer for chemoradiation, but now they say, well, there's a chance for downstaging. So they all go to chemo IO. But unfortunately, a lot of these patients get chemo IO, they still get to chemoradiation because surgeons found out they can't operate on these patients. So it's been a kind of a paradigm change, but then also management difficulty actually somewhat. So it's a little controversial, and so we still talk about a lot in our multidisciplinary tumor board, in terms of that a lot of these patients should be. I think they should. You know, if you're going to do surgery for these patients, you actually commit them at the very beginning, before starting any kind of induction therapy. At least that's how we talk about it. I don't know how it is here in Taiwan. I don't know.